Bismillahirrahmanirrahim. We are discussing ankylosing spondylitis. This is chronic inflammatory process which basically involves tendons, joint capsules, and ligaments. While in rheumatoid arthritis, which is where we see a rheumatoid factor is positive and it is seropositive arthropathy, we see inflammatory process involves synovial tissue. But here in seronegative arthropathies, we see inflammatory process involves ligaments, joint capsules, and tendons. As we see, inflammatory process involves ligaments, joint capsules, and tendons. There is associated inflammatory changes involving adjacent bones where these ligaments, joint capsules, and tendons are attached. So we see inflammation in anterosuperior and anteroinferior corner, and similarly posterior superior and posterior inferior corners of vertebrae where anterior longitudinal ligament and posterior longitudinal ligaments are attached. Similarly, we see inflammatory changes in spinous processes where we see that inflamed interspinous and supraspinous ligaments are attached. Similarly, we see that wherever tendons are attached, adjacent bony process also show inflammatory changes, as in ischial tuberosity, greater trochanter, lesser trochanter, and iliac crest. While inflammatory changes are also appreciated in subarticular surfaces of SA joints, inflammatory changes are more pronounced in axial skeleton, including facet joints, costovertebral joints, and SA joints, while these are less common in peripheral joints. There are basically two main stages in ankylosing spondylitis. Number one is active chronic inflammatory changes, which can be seen with the help of MRI, where we clearly appreciate inflamed ligaments around spine. We can also clearly appreciate inflamed tendons and their bony attached portions, which shows meroedema, that is inflammatory changes. Similarly, acute inflammatory changes can be seen in bony corners of vertebrae and around articular and subarticular areas of the joints in axial skeleton, that is at costovertebral joints, facet joints, and SA joints. So this condition which have active inflammatory component, we see two things. Number one, inflamed tendons and ligaments. Number two, inflamed adjacent attached portions of the bones, that is around joints in subarticular areas. They will show increased signals on fat suppression MRI images. Similarly, bony corners in the vertebrae will also show increased signals on T2 fat suppression sequence, favoring active component of chronic inflammatory disease process. Here we see ankylosing spondylitis in the shape of bilateral sacroiliitis. This is acute phase where we see inflammatory changes in articular and subarticular areas in the shape of increased signals on T2 fat suppression sequences. Later on, in second stage, we see erosions of the articular surfaces with combination of inflammatory process and sclerotic changes. So mixed signals will be noted on T2-weighted fat suppression sequence, showing active inflammation and healed sclerotic areas as low signal intensity areas. So whenever we see erosions, we see there is widening in the joint space, there is irregular articular surface, and adjacent marrow shows mixed signals, that is both inflammatory active component showing increased signals, while sclerotic changes will show reduced or decreased signals in these areas. Third stage is the stage of healing, that is sclerotic changes will take place. Subarticular areas will show increased deposition of the bone, which appears high density on CT and on X-rays, while it will show low signal intensities on T1, T2 and fat suppression sequences. And in this stage we usually see that there is narrowing in the joint space as well. And in last stage we see the ossification process that takes place along ligaments around the joint, leading to bony ankylosis. So in this phase we cannot see joint space properly, both on CT and MRI, while similar changes are also noted in the X-ray as well. Overall, on MRI there will be decreased signals in these areas, suggesting ankylosis with total loss of joint space. So this is called bony ankylosis. Here we have an example of the facet joints, where initially we see inflammatory changes involving subarticular areas, which appears better on MRI only, and we see hyperintense signals on fat suppression T2 weighted sequence. Later on we see erosions, that is there is erosion of the articular surfaces, number 1, and number 2, joint space widening, and number 3, combination of sclerotic changes and inflammatory process, which shows mixed signals on fat suppression T2 weighted sequence. And later on we see sclerotic changes, that is the healing process takes place. We see deposition of calcium, that is increased density in subarticular areas with narrowing of the joint space. These increased density changes can be seen on X-ray and on CT scan, while on MRI they give reduced signals both on T1, T2 sequences and even on fat suppression T2 weighted sequences as well. So this is sclerotic phase, and at the end we see deposition of calcium along the joint, favoring ossification, leading to ankylosis. So these 4 phases, as we have noted in the SI joints, can be seen on in facet joints. So at the end there is summary of the ankylosing spondylitis. This is seronegative spondyloarthropathy with the male predilections 3:1, and it is more common in the young adults in their 3rd decade of the life. And we see that axial skeleton is 80% involved, while peripheral joints are involved in 20% of the cases. Rheumatoid factor is negative, so we say it as a seronegative arthropathy, while HLA-B27 is the gene with strongest association. And we all know that costovertebral joints, spine, facet joints, SI joints, peripheral joints, and ligaments, tendons and capsules, they show inflammatory changes. and inflammatory changes are also appreciated at their bony attachments. There is inflammation in the joints initially, which is better visualized on MRI, number one. Similarly, active inflammatory changes noted around joints and in the vertebrae are also appreciated or assessed with the help of MRI, especially on T2 fat suppression sequences. And at the end stage, we see ankylosis, which can be seen with the help of X-rays, CT scan, and even on MRI. In the joints, we see not only inflammation, but later on erosions of the articular surface leading to the widening of the joint space, and sclerosis with narrowing of the joint space. We see that whenever there is a process of sclerosis, it shows increased density both on X-rays and on CT, while low signals will be noted on T1, T2 and fat suppression T2 weighted sequences on MRI. At the end, there will be ossification and ankylosis. We will not be able to see joint space, and ligaments will show ossification. Here we have associated diseases. In the eye, we see anterior uveitis, which is noted in 25 to 40% of the cases, while in cardiovascular system, we see aortic valve diseases, aortitis, and in 1% of the patients, we see apical or upper lobe interstitial lung disease. Similarly, inflammatory bowel disease like ulcerative colitis and Crohn's disease is also associated with ankylosing spondylitis. So this is the part 1 of basics regarding ankylosing spondylitis. Inshallah, in second part we will see all these disease processes on X-ray, CT and MRI. Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuhu.